Okay, so we know vestibular migraine is a clinical diagnosis. But really, that diagnosis all comes down to making two absolutely critical decisions. Who needs an audiogram and who needs an MRI? If you can answer those questions correctly, you can get effective treatment started right away without all those frustrating delays. So let's build the framework to do exactly that.
And this is the question, isn't it? It's the one every single one of us faces. A patient walks in with recurring vertigo, and that immediate instinct can be to just scan. But is that really the right move?
And here's the punchline. If you order an MRI on every dizzy patient, you don't just strain the system. You actually delay treatment for the huge majority who have vestibular migraine. The standard of care isn't to scan everyone. It's to scan selectively, guided by really clear red flags. And that's our goal today, to build that confident, selective framework.
All right, first things first. We have to be able to confidently sort through the mimics. And this isn't about memorizing long lists. It's about building your pattern recognition skills for the four most common things that can look like vestibular migraine.
This pathway you're looking at, it simplifies the entire diagnostic process. It all starts with the dominant clinical feature. Just asking one key question guides you right down the correct path. So, is it positional and really brief? You're almost certainly dealing with BPPV. Is there a clear change in hearing? You gotta think Ménière's. Are migraine features the main event? Well, that points directly to vestibular migraine. Or, are there central neurological signs? That's your big cue to investigate for something more serious.
So let's break it down even more. This table pairs each of those mimics with its decisive test. For Ménière's disease, an audiogram is absolutely key. You're looking for that fluctuating, low-frequency hearing loss. For BPPV, a simple Dix-Hallpike maneuver in your office can clinch the diagnosis. And if you have any suspicion of a posterior circulation TIA, well, the HINTS exam and an urgent MRI are completely non-negotiable. And remember, things like anxiety and PPPD often coexist with vestibular migraine. They're part of the picture, not a substitute diagnosis.
You don't always need fancy, expensive tech. Often, the most powerful diagnostic tool is the one you carry with you every day. A really focused bedside examination. Now, between attacks, the exam for a patient with vestibular migraine is typically completely normal, so its main job is to confidently rule out everything else.
So here are the four high-yield steps. First up, an oculomotor exam. You're checking smooth pursuit and saccades to help screen for any central problems. Second, the head impulse test, which looks for a unilateral peripheral loss. Third, positional testing with a Dix-Hallpike and a supine roll. That's your go-to for ruling out BPV. And finally, a quick screen of hearing with tuning forks and checking their tandem gait. Can pick up asymmetries or any cerebellar signs. It's fast and it's incredibly effective.
And this brings us right to the main event, a clear, evidence-based guide on when to actually use these advanced investigations. Let's separate the must-dos from the rarely neededs.
So this is a crucial point. Audiometry is the Ménière's decider. You should order an audiogram for any patient with recurrent vertigo who also tells you about auditory symptoms like tinnitus, a feeling of fullness, or any hearing change. In classic vestibular migraine, that audiogram is going to be normal or just show symmetric, age-appropriate loss. But if you see a fluctuating, low-frequency sensory neural hearing loss, well, you've just diagnosed Ménière's disease. Simple as that.
Now for the MRI. When should you order one? The answer is simple. You order it when red flags are flying. This slide lists the key things to look for. Any progressive neurological signs, a really specific nystagmus pattern like downbeat, asymmetric hearing loss you find on your exam or on an audiogram, a first-ever presentation in a patient over 60, or a first attack in someone with significant vascular risk factors. These are your triggers for imaging.
I really want to pause on this because it's the core principle of this entire explainer. Over-investigation delays treatment. Every single unnecessary test you order is time that your patient is not getting the therapy that could actually reduce their attacks and give them their life back.
And this just says it all, doesn't it? This is the other side of that coin. In a patient who has a classic story for recurrent vestibular migraine, and you do an exam between episodes and it's completely normal, you do not need an MRI. Have the confidence in your clinical diagnosis and move straight on to management.
Okay, let's wrap this up and bring it all together. Here are the most critical, practice-changing points from everything we've just covered on the differential and investigations.
First, use audiometry. It's your #1 tool to decisively separate Ménière's disease from vestibular migraine. Second,
MRI is for red flags only, period. And third, and this might be the most important takeaway, in a patient with typical vestibular migraine, your best move is to start treatment. Don't get stuck chasing unnecessary tests.
So, now that you can confidently diagnose vestibular migraine, what's next? Well, in our third and final explainer, we are going to deliver the complete management plan. We'll talk about how to use a 6-week trigger diary, how to choose from the 4 first-line prophylactic agents, and the explicit criteria for when you should refer.
Thank you so much for watching this explainer. For some great downloadable cheat sheets and patient resources, head on over to AustralianDizzinessClinics.com. And hey, if you found this useful, please subscribe and leave a rating. We'll see you for the final part of the series.